Hello, everybody. Welcome to Grand Rounds. Thrilled to have you with us on this Monday afternoon, and delighted to welcome our special guest today, Dr. Priya Nori, who is an associate professor of medicine in the Division of Infectious Diseases and Orthopedic Surgery over at the Albert Einstein College of Medicine over at Monty. She is the program director for the ID Fellowship program over there, and nationally serves as chair of the Infectious Disease Society of America's subcommittee for antimicrobial stewardship curricula, the vice chair for the SHEA Antimicrobial Stewardship Committee, and was also awarded the ID Fellowship Teacher of the Year in 2015, the Department of Medicine's Rising Star in 2017, and the Subspecialist Teacher of the Year in 2020. And we'll get to hear about how both of those things overlap and relate to her talk today. So Dr. Nori, thanks so much for joining us from uptown a little bit.
Yes, thank you so much for having me. And it's so nice to see familiar faces in the crowd, and this is such a great, friendly environment. I truly appreciate that. Thank you for the lovely introduction, Dr. Wiseman. So I'm going to share my slides, and just give me a thumbs up if we're good, if you can hear me and you can see my slides. Thank you. So it is truly my pleasure to be here today speaking about the convergence of stewardship and medical education, because as stewards, this is not really a talk we get to give a lot. Mostly it's like us talking at people about why they're doing things so badly with antibiotics, or as is the perception. But here, actually, we're going to take a step back, and rather than me explaining how to treat X, Y, and Z infections, because you have folks for that. You have a fantastic stewardship team there, both locally and in the system. We're going to instead pause and think about why we do the things we do. And so let's take a look at our learning objectives today. So first, we're going to understand some of these psychological drivers that lead to antibiotic prescriptions, inpatient, outpatient, and how these actually influence the patient's care. Next, we're going to use some examples that come up very frequently, some common clinical scenarios, to discuss how we might not just optimize antibiotic use, but kind of teach how to optimize antibiotic use. So for instance, if we're designing an intervention for interns or for ED docs or for discharge PAs, what have you in terms of the learning group, we're going to think about not only hammering home the points that we want to get across, but understanding how to speak their language in terms of their level of learning. And then finally, we're going to design a med ed intervention, or at least select one, to think about implementing in our various practice settings and the steps to go about doing that. And so I think that, hopefully this is a perfect topic for this audience, because I know you have a really fantastic medical education track in your training programs. So first, let's just talk about what stewardship is for those who may not know. Stewardship is this really fantastic concept, I think, throughout medicine. Does not just apply to antibiotics, but also testing stewardship, imaging stewardship, stewardship of hospital beds and resources and ventilators, all the things that we did during the disaster that happened in 2020. But this is a really, I think, sophisticated concept of taking what we have, which is a finite resource, and using it in the best way that we can. But why do we have to do that as pertains to antibiotics? This is something that stewards recite in our sleep, but basically 50% of all human antibiotic use is unnecessary or inappropriate. So even if it's the right drug for the right bug, we often miss the mark in many other ways, and I'll show you that. And when I say we, infectious diseases is included in that group. While we are currently contending with many disasters as pertains to public health, we have to reckon with the fact that AMR, or antibiotic resistance, is the silent pandemic that has been going on for years, has been accelerated by COVID-19. And by 2050, so only 30 years from now, it would have claimed many more lives than COVID. It is also extremely costly. So C. diff is an example. C. diff is a hospital-acquired infection most of the time, or frequently that leads to $6.3 billion of hospital expenditure in the US per year. And that is money that hospitals like ours do not see in reimbursement because, we kind of messed up and we iatrogenically sometimes cause those C. diff infections to happen. So therefore, it is essentially the law of the land now in the United States that every single hospital, outpatient clinic, dialysis center, long-term care center has some type of team like ours, the antibiotic stewards, who are usually ID docs, ID pharmacists, who are helping to not tell people they can't have antibiotics, but rather optimize those antibiotics, pick the right drug, the right dose, duration, route, etc., along with the primary stakeholders, folks like you guys, to optimize patient outcomes and to reduce these collateral events such as C. diff and AMR. And in doing so, while this is not top of our agenda, we may actually improve things that the C-suite cares about. Things like hospital costs, readmissions, quality of care and patient satisfaction. So basically anywhere that someone can prescribe an antibiotic, there should be somebody like us thinking mindfully about whether or not that's needed and how best to deliver that care. And this includes veterinary medicine. Now, we are focusing today on human antibiotic consumption, but there's a whole beast out there, which is veterinary medicine and agriculture use, which is a thing. I just want to acknowledge that that is certainly a concern, but we're going to put a pin in that today and just deal with mostly what we see on the inpatient side. So despite our best intentions, we kind of missed the mark with antibiotic prescribing in a number of different ways. And here are the common ways that we encounter as stewards, but also we perpetrate as ID docs, as medicine docs, even the very experienced ones. So for instance, the indication might not match. We see this on the outpatient side when in pediatric practices, when a child is coughing and sneezing, clearly they have adenovirus or something, and they get an antibiotic prescription, which we know is only treating the parent's psyche, but not necessarily treating the child. Likewise, something we see not uncommonly in the setting of acute sepsis presentation, let's say in the emergency department, is that we throw the kitchen sink, and the kitchen sink might be something that has absolutely no role. So one of the fundamentals of ID is that IV vancomycin is exclusively a gram-positive agent, and urinary tract infections are almost exclusively gram-negative with a few exceptions. And so we could kind of miss the mark in that way. Dose is another big one we see. Dosing is very nuanced. You might have a little old lady from a nursing home, or you may have a very robust 35-year-old male, and those two should really not get the exact same drug, the exact same dose, et cetera, because they're very different hosts. One very easy low-hanging fruit that we can impact virtually as soon as we get back to our inpatient floors is that we can take a look at who is able to take PO and quickly switch those patients from intravenous antibiotics to oral ones, but all the while that they remain on intravenous when they can take PO might prolong hospitalization, might leave the catheters in place longer, and then the downstream consequences. And then finally, my favorite one right now, which I'm kind of obsessed with, is this whole concept of restarting the clock. The patient was admitted for a routine CAP or HAP. They got their antibiotics, but there's confusion in the discharge summary, and then they end up restarting. So they get virtually double the amount of antibiotics that they needed. And so many ways to get it, unfortunately, wrong, but today, we're going to talk about how maybe to go about making incremental changes to get some of those things right. But here's what we're up against. Unfortunately, of all the public health issues, lots of which are not even listed here, like conflict and climate change, et cetera, antibiotics rank lowest on the priority list for primary care docs, especially because they have so many pressures, so many real and existential threats. And antibiotic resistance becomes even more existential because it's not necessarily right here and now, whereas the patient may be a poorly controlled diabetic now. At this point, they're obese right now, and they may have an substance use disorder. So you can see how it kind of falls to the bottom of the priority list. If you open the paper these days, it's virtually impossible not to just become totally overwhelmed by all of these real and existential threats. And again, where does AMR fit in that priority list? And probably low, but we have to acknowledge the fact that all of these things actually intersect with antibiotic resistance, are going to worsen this. Things such as reliance on fossil fuels, which worsens respiratory conditions, which worsens the need and the antibiotic selection pressure because these patients get chronic courses of antibiotics. Drought, mosquito-borne illness in unstable climates, poor sanitation, famine, pandemics for sure. I mean, that's a whole other, we can spend hours on that. And then finally, things like conflict and wars, where we saw the reemergence of infectious diseases like cholera, like drug-resistant salmonella. I mean, all of these things will intersect with AMR. So we kind of have to deal. And this should be reframed as not just an ID issue or a public health issue, but really a household issue. And so let's first think about what are some of these pressures that lead to antibiotic prescriptions. Now, there are patient pressures and family pressures, and then there are prescriber pressures. And unfortunately, none of these things are said out loud. So we're just like in the dark, and it's the elephant in the room, and we're not talking about it. So a patient and the family, they came for a service. They brought themselves into a crazy ER looking to get diagnosed and treated quickly for something and to improve. And our desire as people pleasers is to meet those expectations quickly as providers. Patients also want to know what's happening. They want answers, and they want a clear plan, and they want their expectations met. And our concern on the other side is that, what if I got their diagnosis wrong? What if I missed that? I mean, I'll give you an example. The other day, I missed endocarditis as an infectious disease provider in a patient I've been taking care of for literally 5 years or more. And he was admitted to the hospital with these recurrent episodes of bacteremia as a substance use, as someone suffering from substance use disorder. And I totally missed that. And so, that had severe consequences for that patient. There are also misconceptions about what conditions antibiotics treat and what they don't. We're doing a better job with that now because we were forced to do so with COVID, and really hammer in the point that COVID is a virus. You cannot treat it with ivermectin, which is an anti-helminthic. You cannot treat it with azithromycin, which is an antibiotic. But for many, many years, patients really didn't make that connection. And then especially, I would say on the outpatient side, but also tremendously for house staff in the ICUs, there's so many things fatiguing you and leading to decision fatigue and burnout, that the last thing you have the brain cells for is to really rationally and judiciously think about antibiotic prescribing. And so this is a vicious cycle. Patients get antibiotics for a similar condition in the past, and they want that again. And then for us on the provider side, it's a vicious cycle, because every time we give an antibiotic, every subsequent time, we feel obligated to give something broader and broader and broader. And so for those who are interested in kind of some of these behavioral motivations behind not just antibiotic use, but so much of what we do in medicine, I encourage you to follow this woman who's absolutely amazing. Her name is Julia Simchek. She's a medical sociologist based out of UPenn. And basically she spends her entire life's work is figuring out why we do what we do, but her current focus is antibiotic prescribing. I won't go through all this in the interest of time, but there are a couple of important ones here, which I do want to mention, because I hope that they resonate with you all, because they certainly resonated with me when I read about these. So we tend not to interfere. There's this unspoken non-interference culture. When we see that a colleague has prescribed an antibiotic, we don't want to pass judgment, and we don't want to question their judgment. Likewise, when a senior person, let's say a chief resident or the ward attending is telling us to order an antibiotic, we're certainly not going to question that, because the systems built around us were not designed for us to question authority, but have functioned for many, many decades under this hierarchical structure. Some specialties more than others. I think it's particularly profound in let's say, general surgery. On our side of things as the prescribers, we perceive that under treatment of the patient's condition or a watch and wait approach is actually worse than potentially the INR going up because of antibiotics or acute kidney injury or an antibiotic rash or something. That's something we're willing to take the chance on, because for us, the patient not getting treated for the infection, potentially dying, is just about the worst consequence that we can face. And so broad spectrum antibiotics are almost like an anxiolytic, and they help us to take a very uncertain situation and make it into a safer situation. There's also this perception, and I would say this is particularly strong in ICUs, where an ICU doc may say, well, my patients are sicker, so I don't think the IDSA guidelines for HAP or VAP necessarily apply to my patient. Therefore, I'm going to go ahead and give 2 or 3 antibiotics to treat that one bacteria versus follow what either the national or the local guidelines say, because we're out of this realm of evidence base in their opinion. And then, of course, this never-ending cycle. It worked in the past, so I'm going to keep doing that again. And then we must acknowledge what's going on lately with healthcare worker burnout and fatigue, but this is major as pertains to our ability to really give it our all in terms of antibiotic decision-making. Here are some dogmas that have persisted for decades, and even ID docs are guilty of perpetuating these. So one that we deal with frequently is a patient admitted for pyelonephritis. They may have transient E. coli bacteremia, and that's kind of stuck in our heads from med school. Maybe it came from that, Microbiology Made Ridiculously Simple, or one of these books. And it got stuck in our head, the 14 days. Bacteremia equals 14 days. But now there are many studies actually challenging that and stating that actually 7 days are probably non-inferior. And likewise, there's multiple things like that that are just fixed. And it's as if somebody tattooed them on our brains for sure, but probably on the patient as well. And one of these that I'm going to spend some time on today is this urinary syndrome in an elderly person who may present with a fall or altered mental status. And oh, look at that. They have a positive UA in culture. I figured out what they have. I want to deal with that and I want to move on. So knowing how many ways how many possible ways there are to go wrong with antibiotic prescribing, how can we actually move the needle in the right direction where we get people prescribing more in the vein of evidence-based and best practices? Well, we can't beat them over a head with a hammer. We can't throw the entire guidelines at them, expect them to digest that and then apply that in one day. And so we have to focus on these incremental nudges. So this nudge concept in medicine not only applies to ID and antibiotic prescribing, but virtually anything, any type of behavior change that we're wishing to enact really starts with these small nudges. And it's not about speaking at the provider on the front line. It's about getting them to meet you halfway and almost, I don't want to say manipulating them, but getting them to think it was their idea to get to that point where you're both seeing eye to eye. One thing that we have to respect is the conditions on the ground. So as an antibiotic steward on the phone, I cannot judge the ED provider who's taking care of a dozen septic patients and has to make decisions about antibiotics extremely quickly to avoid really bad outcomes. Likewise, we cannot set up a million hurdles in the workflow of the typical intern or resident or hospitalist. And we have to avoid these things that are well known to lead to burnout, like excessive EMR clicks, best practice alerts, et cetera. It's all about coming to this place together where we're all on the same page. And of course, that sounds very idyllic and easier said than done, but there are successful examples of doing so. The first one I like is from AHRQ. This is even before that antibiotic is ordered. This gives prescribers, doesn't matter if they're in a nursing home, in the ED, in the outpatient side, inpatient side, it gives them a framework to even embark on antibiotic prescribing. And so there are 4 moments. Moment 1 is, does this patient even have an infection? Like, for instance, does this patient have COVID or do they have community-acquired pneumonia? One requires one pathway of treatment, one requires the other. So understanding that always has to be the first question. Is this an antibiotic treatable condition? The second one is, okay, did I get the right diagnostic tests? And did I get them before starting antibiotics so that I know in 2 or 3 days what I'm dealing with? Finally, fast forward to day 2 or 3 in the patient's hospitalization. What can I do now? Is the patient equally sick as when they started, or are they better? Do I have enough information to de-escalate or even stop if nothing came back positive? And then finally, I know what the patient had. I found out. I know how to treat that and for how long. Am I making sure to convey that to the patient, to the family, to the other provider teams, and then finally to whatever is the next step for that patient, long-term care, assisted living, or just home. So at multiple points in the patient's care continuum, we have to ask ourselves these questions. Is the antibiotic that I started still the right way to go today? So now we have this framework, I hope. Let's go through some what I think are extremely common, not exotic scenarios. We are not going to learn about malaria or yellow fever or anything today. So this is a 75-year-old female from a local nursing home with osteoporosis, mild Alzheimer's dementia, recent hospitalization for a fall and femur fracture, for which she got a fracture fixation. She briefly had a post-op Foley because she retained urine for a few days. And then now she presents to the ER with 2 days of confusion and sleepiness. She's receiving oxycodone PRN at the nursing home for post-op pain, otherwise no changes to her medication regimen. Her vitals are all very stable, normal-ish blood pressure, pulse, heart rate, O2 sat, and even her temperature is not concerning right now. She's difficult to arouse, but otherwise comfortable. She has no suprapubic tenderness, no flank tenderness, but her UA is positive for nitrite silicestrase and her urine culture is positive for 50,000 E. coli. So maybe we'll pause here and maybe if you guys can engage with me for a second via the chat function or the thumbs up function. Is this familiar to people? Have you dealt with such a patient, let's say in the past month? Okay. So there are multiple triggers that we've learned over time for going down this dark hallway of a diagnosis of UTI, especially in elderly folks. It's become kind of fixed in our heads that a strange color of the urine or a strange smell or sediment or cloudy urine somehow has become associated with UTI, especially if the patient has other signs like somnolence or confusion or whatever. But we have to recognize that in especially elderly folks, people coming from long-term care, and especially chronically catheterized patients, they have bacteriuria 99% of the time. Bacteriuria, besides being extremely hard to say, is basically a state of constant colonization of the urine with bacteria without necessarily indicating the presence of a clinical syndrome such as UTI. Okay, so all of these things that we see are not necessarily reasons to either work up for UTI or subsequently treat a UTI. And so pyuria or white blood cells in the urine or bacteria in the urine in the absence of clinical signs are not specific or sensitive enough to warrant antibiotic treatment. So I mentioned pyuria, but why is this? What else can cause pyuria? It's very nonspecific. Having that catheter alone as an inflammatory state can lead to white cells in the urine, bladder distension or urinary retention. Sometimes meds can do this, and bacteria being there without the patient having a UTI can also lead to white cells in the urine. So it's best to avoid even trying to send the diagnostics for UTIs. And so there's a huge movement now in medicine, which is diagnostic stewardship, and urine testing stewardship is huge on that list. So thankfully, there is some framework, there are guidelines to help us to understand when urine cultures, urinalysis, urine cultures are needed and when they are not. So remember that a definition of a UTI really involves the clinical presentation, the slam dunk, very specific symptoms, so dysuria, lower abdominal pain, fever, hypotension, etc. But cloudy or smelly urine alone are not enough, even if the urine is quote unquote dirty. And this is important to recognize because so many of our elderly patients that we admit will have this. And we may throw antibiotics at them. We may miss a diagnosis such as a stroke or something else bad that's affecting their cognition. And we may even give them renal toxicity, C. diff, interactions with their other polypharmacies. So there's multiple reasons why we should think twice about the situation. Okay, so if you have questions about that, feel free to put them in the chat and we'll get to them toward the end. So here's another scenario, which I think hopefully you guys also see all the time because I certainly do. This is a 75-year-old male with COPD on home oxygen, is admitted with his third COPD exacerbation in 1 year. The chest x-ray shows a lobar infiltrate consistent with bacterial pneumonia. He has received prior courses of antibiotics and therefore is started on broad spectrum antibiotics. So remember that kind of empiricism that I mentioned before, we have to keep upping the ante until we've not hit the ceiling on broadness of antibiotics. So he's treated with piperacillin tazobactam for 5 days and he improves and he's ready for discharge to a skilled nursing facility. But unfortunately, the recommendations are vague and it says 5 days, but it's not clear if that's 5 more days or what. He ends up on 5 additional days of levofloxacin. And so this is a new, very important movement in antibiotic stewardship and in hospital medicine and just in medicine in general, which is transition of care stewardship. So that may mean a patient going home, a patient going to a long-term care, or even moving units. So from the ICU to the general medical floor. Restarting the clock with antibiotics at that juncture is extremely common as well. So those points in the patient's care continuum are certainly ripe for intervention. So this is a fantastic study. I just want to mention this woman who's a friend and is also just an absolute powerhouse in hospital medicine. Her name is Valerie Vaughn. Please please explore her work online. She's also on Twitter, but she basically has established a multi-center hospital antibiotic safety program where they look at how to improve safety as pertains to antibiotic use, especially for very common conditions like pneumonia, urinary tract infections. So in her work, what they were able to ascertain is that antibiotics are basically prescribed to greater than 1 in 8 patients at discharge, and approximately 50% of these can improve either by just being stopped or being tightened up in terms of duration or dose or whatever. But what they identified as reasons for this is that as providers, we worry about these settings that they're going to. Are they going to get the attention that we've been providing for them on the acute care side? If they're in a less monitored setting, isn't it better that we kind of cover the bases with a little bit more antibiotics just in case something bad happens? And so that is a common driver of this phenomenon of resetting the clock. Also, how many times have you received a patient from a skilled nursing facility who's been on antibiotics, but you're not able to figure out which ones, you're not able to figure out why, and it's a bi-directional miscommunication from us to long-term care and to long-term care back to us. And so there are tremendous opportunities to tighten up stewardship at discharge. One of the big pitfalls we should try to avoid is excess quinolone use. I don't have too much time to get into that today, but quinolones in particular have a bad safety profile, especially in the elderly. Lots of neurologic issues, vascular issues, tendinitis and tendinopathies, and the list of side effects is mounting year after year. And so it's best to avoid these if we don't need to prescribe them. And so the results of this multi-center intervention in the state of Michigan, what they did was basically they redirected their stewardship manpower and resources and attention, not toward what was being started in the hospital or how long or the doses, but they pivoted to the point of discharge, and they went all in on trying to tighten up the discharge summaries and try to reconcile these antibiotic courses at discharge. And they made a huge impact in terms of both pneumonia and UTI. They got lots of patients off antibiotics. They avoided C. diff, readmissions, just so many things. And why I love this work and why I love stewardship is that this is all common sense. It's not erudition. It's not anything that any one of us couldn't make happen. And so you can clearly sense my passion for this topic, even though it's not super exotic, but nevertheless requires lots of us to be plugged into these issues and try to move the needle. Okay, yet another common inpatient scenario. So this is a 70-year-old male with multiple myeloma, diabetes, BPH, 48 hours of dysuria, decreased urine stream, and blood-tinged urine. So now these are slam dunk signs of UTI. So in absence of these, but with a positive UA and culture, I don't know that I would necessarily put the same emphasis on getting this guy treated. So he had a prostate biopsy 3 days ago. Currently, he's a little hypotensive, tachycardic, and he's febrile. So he's septic. The sepsis alert is activated. Urine dipstick is positive, and he's ordered for piperacillin tazobactam because I don't know about where you guys are, but for us, if sepsis is activated, free first dose of antibiotics because time is money, and these are CMS imposed rules more or less. However, an epic alert fires saying that the patient has a penicillin allergy, but it's unknown. It's not clear what that is. So what now? How do we deal with that? Do we just pivot to a different antibiotic class altogether, or do we actually try to take a few minutes to work through this and see if a penicillin-based antibiotic is still the way to go? So here's what we need to understand, and here's what we as educators need to impart on learners on the front line about antibiotic allergies and the harms related to antibiotic allergies. So we call this mislabeling patients as being antibiotic allergic. And this is sort of like, when you're in school and you got in a fight with a kid and you were suspended, that ends up going on your permanent record, and that may then impact every subsequent opportunity in your life. Same here. I kind of make that parallel because I say that these antibiotic allergies end up on the patient's permanent record. And so what happens is that they're not frequently given the right antibiotic, the most effective one for what they have. And this follows them every single hospital that they're admitted, every single healthcare setting. And we are not doing them a service by continuing to perpetuate this myth. The reality is that 1 in 10 so 10% of patients in the US report a penicillin allergy. But when you go to skin test them, which is taking advantage of preformed IgEs and trying to invoke a type 1 hypersensitivity, 9 out of 10 patients are not truly allergic. So they don't have those IgE antibodies that cause immediate hypersensitivity reaction. And that is truly the one that's scary because that's linked to, anaphylaxis, bronchospasm, all the scary reactions that we worry about, but yet hardly ever see in the hospital. Not only that, but the other fact that we can take advantage of is that 80% of patients with IgE-mediated penicillin allergies lose them after about 10 years. So even if somebody reported that at the age of 10, I was given amoxicillin for strep throat, I had a terrible reaction, well, now they're 75. So the presence of those IgEs in their system still from that initial event is very, very unlikely. And so when we continue down the path of a mislabeled allergy, what happens is patients get more broad spectrum, suboptimal, more toxic agents, and studies show that there are higher rates of C. diff, of drug resistance, of surgical site infections, and increased length of stay. So all the things we kind of hate on the inpatient side. Okay, and then the last concept is, of course, the cross-reactivity thing, which again, going back to when I was in med school, I learned that it was much higher than it actually is in reality, which is somewhere between 1% and 5%. And these newer antibiotics, which have all these fancy side chains and stuff, are definitely not going to be recognized by those same preformed IgEs. So how do we make sure that the very busy docs and PAs and nurses at the front line can relate to these concepts and can internalize them and put them into practice? I just gave you a bunch of information, right? In 5 minutes, I told you like 10 different facts about antibiotic allergies. And I don't know that you're going to internalize or connect with or apply any of them, because maybe I didn't go about the right way to impart that knowledge. So what we have to do when we're trying to get adult busy learners to learn new information is we have to take advantage of certain well-studied and well-known cognitive learning strategies. So these are things like spaced retrieval. So again, don't give them a deluge of information, give it in doses over time, spread it out, revisit it multiple times, and it is more likely to be retained. Interleaving is basically enhanced retention when different information is presented at a time. So today we'll talk about side chains. Tomorrow we'll talk about IgEs. So you can't just, again, we have to avoid just dumping a bucket of information over their heads like how we used to learn in med school. This is now a different ballgame. Generation and elaboration. So there is enhanced retention of knowledge when we can create a situation where learners apply this information to problem solve and work through clinical scenarios and such. And then finally, we end with reflection, where we ask them, okay, how did you connect with that information? How did it, not to be touchy-feely, but how did it make you feel to suddenly understand that or learn that or understand the impact that it might have on the patient? So you have to really try your best to connect the content with the learner, and you're therefore more likely to be successful. So this may be familiar with anyone who's even taken basic medical education didactic courses, and this is the current 6-step guide to curriculum development. And this is like not changed in many years. This graphic, every time I search online, this is exactly what I get. But what I'm going to do now is I'm going to try to contextualize this with the stewardship intervention. So taking that patient, antibiotic allergy, sepsis, what do we do now? How do we make sure that our frontline learners know that that's okay? We can still give this guy beta-lactam because his allergy happened so long ago. So identify the problem. What's the problem? The problem might be something like too many of our patients are getting quinolones who have documented antibiotic allergies, and then therefore getting something like C. diff. Then we conduct a needs assessment, which is what is people's knowledge base about antibiotic allergies and how to delabel them? And then we create a set of very discrete goals and objectives. What do we want them to understand about antibiotic allergies and the impact on patients? How do we want them to reflect my experience as an ID physician and a steward? And how do I want to kind of transform their thinking to think more like the people on this side of the aisle? Finally, what is the best way to teach these concepts? Is it with a series of educational lectures? Is it something practical and hands-on? Is it case-based? Multiple different ways. There's no right answer. And sometimes it's a matter of combining all these things and designing a multi-pronged intervention to give them different experiences over a spread out time frame. And then it's really important, especially if you want to take what you did and take credit for it and turn it into an abstract or something to submit to the MedEd portal, or really any number of opportunities. You want to be sure that you can measure what you did. And for stewardship, the way we measure is antibiotic use. So we check all the administered antibiotics in EPIC and we say, where did we start? Where are we now? And we're like, yes, success. We successfully brought down quinolone use. But in medical education, that's not enough, right? It's not just about the end result or the outcome measure. It's also a lot about the process measures along the way, which are, how did the learners relate to that content? Did they like the methods we were using? Was it within their workflow, or was this a whole other kind of hassle for them to engage in? And then you want to create some kind of feedback tool where they can actually give you their reflections and thoughts on what you did, so you can use it to tweak your future interventions. So this is kind of a combination of process improvement and medical education for adults. The other thing that is really important, especially if you want to be successful and you want to create something you can actually achieve, is to make sure that your ask, your goals, your intervention are discrete and that they're not huge. You don't want to cast too wide of a net. Otherwise, you'll never get to that point where you say, yes, this was successful. And of course, give yourself enough time to pull this off. You're going to have to pull in so many different people. Let's say you decide to create an electronic order set or something. You're going to have to pull in EPIC. You're going to have to pull in multiple disciplines that all are going to be end users of that order set. So you want your intervention to follow this SMART AIMS framework, which is that it's specific, measurable, actually something you can achieve in some reasonable time frame, and relevant to the people on the ground who are working with this stuff every single day, day in and day out. However, whatever we design, whether you are a hospice attending designing an intervention for PAs, or an ID attending designing something for fellows, or some pharmacist designing something for the ED, you have to think about provider autonomy. If you create an intervention that takes away all their autonomy and creates these quote unquote hard stops in EPIC, that's not going to be received very well, because providers' autonomy is very important for them to be able to feel like they're in charge of the decisions, that they're being trusted. Anything that removes autonomy is unfortunately going to contribute to burnout and isolation and fatigue and all of those very negative things in healthcare. So it is definitely a balance. While education alone is certainly not enough, you can teach it as many times as you want, but you have to give them tools to actually apply it. But it can't be so draconian and rote that it takes away their ability to think critically. Okay, so now I'm just gonna pivot to showing some of this in practice. This is the Infectious Disease Society of America's ID Fellows online curriculum, which teaches stewardship concepts, teaches fundamentals of microbiology. What we learned though is, while it was intended for ID Fellows, a whole variety of people all over the world are engaging with it, including hospitalists, internists on the outpatient side, pharmacists, infection preventionists. There's something in it for everyone, and it's fairly reasonable. There's discounted prices. If this is something of interest to you, please let me know. We can totally hook it up, as they say. And so what this is an online module that's iterative, and it's meant to be done over a couple of weeks. And it takes advantage of all these adult learning concepts to teach things like, how is susceptibility testing done? How is phenotypic testing done? What does S mean? What does I mean in terms of MICs? And it's neat. It's very fun. We had a lot of fun creating these fail videos where basically one of us pretended to be, let's say, like a very busy surgical intern who wanted meropenem for pancreatitis, but then the stewardship pharmacist was kind of butting heads with them, trying to convince them of the data. And of course, it went nowhere. But then once we did it kind of modeled how to do it the right way, meeting in the middle, negotiation, mirroring their challenges on the ground, then we were really able to get somewhere. And this is really neat, and it's hilarious to watch. So if you're interested, please let me know. I do want to spend some time on the role of the digital classroom. So this audience, I think, is a lot of young people, millennials and below, and you guys do this way better than we do. You engage with social media, podcasts, other digital portals, sometimes all at the same time. And so you're consuming information from multiple sources, which is so cool. So these days when I'm teaching fellows or I'm teaching medical students, I say, what is the point of memorizing things anymore? When I was in your shoes, I had to memorize, the brachial plexus or whatever is the case for something I never think about anymore. But now everything is at your fingertips. So we have to rethink the way we teach and the way we expect them to learn. And so there are multiple advantages of digital platforms for learning. There's a wide reach, and the ones that are done well harness these key principles of adult learning. And there's lots of excellent ones, certainly in ID, and I imagine there's even better ones because of the expansive reach of societies like SIDP or ACP. There's outstanding online content for internal medicine. So each one of these social media platforms or digital platforms certainly has pros and cons. One thing that none of them have is a peer review. So know that when you're going there, it's a lot of pulling from different primary sources, but ultimately there's a lot of editorializing and people's opinions inserted. So you do have to take it with a grain of salt, but certainly there are multiple advantages, such as fitting in with our lifestyle. The asynchronous platforms really allow us to do multitask and live our lives without feeling like we have to sit in the classroom again. There's multiple visual media for those who are visual learners. And if you're not, you pop in a podcast on, pneumococcal vaccines for 20 minutes while you're driving to work. And auditory learning is certainly very powerful. And the really effective ones have a set of best practices that they conform to, which you can read here. I won't spend too much time, but I just want to mention the reference here, which is a recent supplement to the May issue of Clinical Infectious Diseases. Here's the link, and we'll disseminate this information, but certainly check it out if you are interested in digital platforms for learning and disseminating your medical education work. So we are now toward the end of the talk, but I do want to revisit some of these areas where I see gaps. I see that us as infectious disease docs, pharmacists, stewards have not really gone all the way or leaned as effectively as possible in on these particular areas where we see lots of antibiotic overuse. And so we mentioned allergy de-escalation, antibiotic reconciliation at transitions of care, creating these alerts to prime people to think about if antibiotics are still needed, working with frontline nurses to help disseminate to patients and provide patient and family education on what antibiotics they're receiving and why. And so this is becoming a CMS requirement, by the way, so probably something we do have to think about. And then finally, the lowest hanging fruit, which is probably the easiest to pull off, is just giving pharmacists, staff pharmacists, the autonomy to switch patients from intravenous to oral antibiotics when the patient has a diet ordered, is on other oral antibiotics. Know, though, that there is a huge resource lift as you go up the chain, the food chain, and more resource intense and more time invested. Okay, so going back to this concept of these dogmas of what we do in medicine, know that you have a resource here. There's a gentleman named Brad Spellberg. If you're not already familiar, he's very vocal about antibiotic resistance, about the big healthcare con, which is how middle management is kind of screwing up medicine. But anyway, he has a lot of positive qualities, and one of them is that he has come up with this whole school of thought in ID, which is shorter is better. And he has appraised critically all the studies on traditional courses of antibiotics, let's say up to 14 or more days for routine infections, and compared them with shorter courses. And for all of these indications listed here, and increase, each couple months he adds more indications, you can see that shorter is either non-inferior in trials to traditional long courses, and also in some cases has the advantage of an improved patient outcome because of the avoidance of something bad. So definitely check out Brad Spellberg either online or on Twitter. And this is a really nice resource if you want to understand how long do I have to treat this particular patient for their infection. And these are all evidence-based. So finally, the last thing I want to do, and to leave some time for questions, is as a group, I would love for us to kind of vote and pick one thing that we'd like to focus our attention and create some kind of either process improvement or medical education intervention around some kind of common problem that we encounter all the time in the hospital. And so feel free to put that in the chat. And with that, that is all for me. I would like to thank some folks, especially the people that invited me here today, Drs. Mitaka and Srikala Raghavan, who's my old and dear friend from Montefiore. I'd like to thank our entire antibiotic stewardship program, as well as the stewardship programs at the Mount Sinai Health System and Mount Sinai BI. And I've made so many wonderful friends in this community over time, and I'm really grateful. So I see some votes here. I see number 6 and number 2. 2 people voted for number 2. So let's even remind ourselves what number 2 was. Okay, yes. So we are going to try to create a program around delabeling patients' allergy histories. Fantastic. If you would like to work more on that offline, I can definitely point you in the right direction with some studies that have been done, not so much in New York, but in other major centers throughout the country where they successfully de-escalated allergies and even created apps to help people work through these algorithms. Okay, so let me stop the share and then we can open it up to some questions, if any.
Hi, Priya. Thank you so much for joining us today. So I think, one of the questions that comes up for me, I know that you've done a lot of work with fellows and residents and even students around engaging them on projects with antibiotic stewardship. And so for folks who are interested in bringing that to our trainees here, how would you kind of say that we would get started? Would you say that it would be kind of resident driven? Do you think that we would start with projects and kind of involve them? How did you get that started?
Yeah, so a great question. So I would say I started when I was a fellow. And so the most important thing when you're a trainee is to find that sponsor or to find the mentor with whom you can sit down, figure out with a needs assessment where the problems are, and then design something around that. More than likely, you'll need some kind of team though, because you'll probably need a sponsor, maybe in the stewardship program or one of the ID attendings, but you'll also need someone who understands how things work on the ground. And that might be the chief resident or another faculty member. And so the first step is, I think, finding your passion, finding the hole in your day-to-day work. So as an intern, as a resident, if there is a nagging problem that you perceive over and over and over, like why does every single one of our urinalyses reflex to a urine culture regardless of the results of the urinalysis? I think that's leading to a lot of overtreatment of UTI. So once you find your passion or you find your frustration even, then I think you sit down with a group of folks who agree with you, who also have made the same observations, and then start to figure out who you need to contact, what your intervention is, and obtain some sort of baseline for how bad the problem is, so that you know, so that you can create a target for how much you're going to incrementally improve that problem. So there's always, trust me, especially with these like non-exotic day-to-day problems, someone else is always interested because they've made the same observations about the same pesky stuff that you've observed in your clinical practice.
Hi, this is Sanjana. I'm the medical director of the ASB program for Mount Sinai Beth Israel, and I just wanted to a few comments. First, thank you for a great talk on the behavioral and social determinants. Always difficult to implement, but I think it's important that we continue with it. Also, thank you for one of your earlier papers in 2020 on the antimicrobial use with COVID, which I've often referred to. From MSBI, there are a couple of things that we touched upon. The first is, how staff were interested in our ASB program. We do have residents reaching out, and actually a few, I think the beginning of this academic year, we had 2 residents who wanted to, who expressed more of an interest in it. And they're actually standing members of our ASB committee, and we encourage them. We want to see how this goes for this 1 year and then get their feedback and see how, whether it's something we want to pursue or not. One final comment on, when you talk about the moments, the AHRQ moments, especially, I think one of the low-hanging fruit, in addition to the IV to PO conversion, is moment 3 and de-escalation, which is something that we don't emphasize enough, especially in our ICU settings, where I can understand where all the pressures may come in and you want to be as broad as possible and all of that. But it should always, and this is something I think from ASB, we try very hard to emphasize to our house staff, always followed by that moment a day later when you're taking a step back and looking at everything and trying to figure out what can be peeled off.
That's a huge challenge. I'll share something with you, which is that we don't have it as together as we see. We are trying to implement across our Monty Health system the 72-hour electronic alert that says, your patient has been on antibiotics for the past 72 hours without a positive culture or whatever that the AI technology would detect. Please consider either de-escalating, switching to PO, stopping, consulting ID. We're getting a tremendous amount of pushback because it is being connected with all these alert fatigues and excess clicks, and it doesn't fit with our workflow. And, we already reassess the antibiotics at that juncture. That's what they keep telling us. So then what started as a very lofty intervention that has a good evidence base behind it and is sanctioned by CMS became kind of a very ridiculous thing, which is that our head of IT, where he felt that he was kind of throwing us a bone, is he said, I'll put it as a column in IDT in the patient report, so that at least you can check the box for CMS. So to design something like that is very politically charged, unfortunately. So I think we have to find other creative ways to nudge and encourage people to adopt that behavior without being told via Epic or, the man or whatever. Huge challenge.
I absolutely
don't have the answer to that one.
Right. Absolutely agree. I think clicking our way through things and the BPAs are not helpful.
But when you have a ginormous health system and you're trying to get everyone on the same page, sometimes using Epic might be the only way. And that's a tremendous challenge. I don't know that anyone's reconciled that effectively.
We only have
Dr.
30
Nori.
seconds left, so maybe we'll let Dina ask the last question. Dr. Perlman, my apologies.
Thank you so much. That was a fantastic talk. And, I I really hear what you're saying in the beginning of the talk about the emotion that goes into these, the choices that we make, and how we all have to do better, and you know, looking at our antibiotics. I have actually a short course antibiotic therapy Spellberg talk that I love to teach on, because it's hard to change our ways. And I really appreciate that there's a lot of emotion that goes into it. And also, you know, transitioning care from one service to the next, and how to deal with giving different messages across our ID providers in terms of the right way to go about treatment. And I think that's, you know, we all have different styles, given often the lack of data in doing what we do. And so I think that's, you know, something that I appreciate you bringing up and being mindful of.
Awesome.
Thank you. It's very kind of you to say. So I have my email in the chat,
Yes.
and so I fully welcome anyone to reach out, and we'll figure it out together. That's the bottom line.
Excellent. That sounds like a great way to end. Thank you so much for joining us, Dr. Nori. We really appreciate it.
Absolutely. Anytime. I hope to take the D train down next time.
We would love to have you here in person.
That would be awesome.
Take care.
Okay, thank you.
Thank you, everyone.